Well, good afternoon and welcome everyone. This is the Point of Care Technology session. My name is Brian Dolan. I am the editor of mHealth News and I'll be your moderator today. The session will be structured in a series of short presentations, really just for introduction's sake, to make some of the major points, get a sense of who our presenters and panelists are here today, and really ground the discussion that we'll have following that. We'll do a moderated Q&A for the remainder of the session after a brief 5 to 10 minute prezo from each of us. And hopefully much of that time will be spent with audience Q&A, so hopefully there's a lot of questions out there. We'd love to hear from all of you as well. So, in preparing for this session, this idea of point of care became a focus, and for me, just researching that term, because it's one that's thrown around quite a bit. There's not a lot of agreement as to what point of care means, in my opinion, just from what I've seen. If you look at the AMA's definition of point of care, it's very strict. It says generally implies use of an EHR as data are captured. They refer specifically to use of templates that are software tools that direct the capture of structured, context-sensitive data. Very much a physician-centric definition, as you might expect. I think of it a lot in terms of patient engagement as well. And there's also this idea, of course, point of care having a very specific geography associated with it. It's a location term. So more simply and perhaps closer to the definition I think most of us would believe in, point of care is the location at which patient services are delivered. So this idea of location in the context of this event I think could make this a very interesting discussion, since mobile health is really about disrupting location. It's about healthcare anywhere that you are, not just where your doctor is and where your hospital or your doctor's office is located. So when I first reviewed this panel description, I started thinking about mobile health apps, services, other devices that physicians and patients might use together when they're visiting with each other, typically during an office visit. And that's really a growing category of apps out there, again, related to patient engagement. Some of those I would put in this category of swivel apps, which many of you may have heard. And again, this refers to applications that are found on the physician's device. Typically, it's an iPad these days. And of course, it's the physician turning that screen around. These mobile devices are very easy to work with and collaborate on, and showing the patient, maybe it's an anatomy app, maybe it helps explain in a very visually appealing way what's going on in that patient's body. Maybe it explains a surgery they're about to have, a condition, a disease state. But this is a growing group of applications. Another group of point-of-care apps that comes to mind are prescribable apps. So not just apps that you're using in person with your physician, but ones that maybe you're turned on to from your physician, recommended by your physician or another clinician. And it's really something you then take home and you use on your own for self-managed care. Maybe it's a follow-up regimen that has been prescribed to you. So, a great example there is physical therapy apps. A lot of these therapies are given to you on just a sheet of paper, and you're expected to understand what that's telling you to do. These applications now can show you videos, they can show you animations, or just help you in a more interactive way understand what's expected of you. So in any case, these types of point-of-care digital health services certainly have some potential, and I think that those are some of the things that come to mind when you think about point-of-care in the traditional sense of being at the place of care. That said, I think just maybe one or two of our panelists are really going to touch on technologies like those, applications like those. And the discussion we're going to have, I think, is a little bit broader. And again, that's because of the event we're at here today, the mHealth Summit. So the general trend, of course, is that point-of-care services, point-of-care diagnostics, point-of-care technologies are moving from clinical settings to the home and to other non-medical facilities. This is even taken to a much further standpoint now that a lot of these services are being made available on your mobile phone or your tablet, so they're now available anywhere that you go. Similarly, years ago, mobile phones had a similar effect on voice calls. So we used to only call locations. You'd call your parents' house, your friend's house, your accountant's office. That was the way phones worked. Voice calls were to locations. Today, much more frequently, we call people. So location is less relevant. Phone calls are more personal. And I think that there's a similar transition, a similar transformation that's happening in healthcare today thanks to mobile health. So HIMSS has assembled an eclectic group of presenters today for today's discussion. They're developing and offering a wide range of services that I think are testaments to this trend of the shifting definition of point of care. Some have developed services intended for use on-site with your physician and other clinicians, and others have created services that are decidedly very much removed from the traditional concept of point of care. So since one of our panelists joins us from a leading healthcare provider group, I thought that'd be the best place to start. By way of introduction, our first presenter is Shannon Wendling. You may have seen her speak earlier today. She was on one of the super sessions that was moderated by Don Jones from Qualcomm. Shannon is the director of the eHealth department within the Division of Clinical Innovation at Geisinger Health System. Ms. Wendling is responsible for employing internet and related technology to address patient activation and community provider support. She's developed key strategies for patient activation using the patient portal, patient-reported data, and text messaging. She's also in the process of exploring mobile app use. Her strategies employ technologies such as web portals, the Epic electronic medical record, questionnaire tools, smartphones, touchscreens, and iPads. Her accomplishments include expanding clinical information available in the patient portal, patient-reported data in the clinic setting, and through the patient portal such as medication reconciliation, depression screening, and asthma monitoring, as well as text messaging for appointments, medication adherence, and weight management. She joined Geisinger in 2010 from IBM Global Services, where she spent 14 years as a consultant, sales professional, and sales manager. Her work at IBM focused on process improvement and IT infrastructure to enable business services. So without further ado, please welcome Shannon to the podium.
Do you want to bring up my presentation? There you go. Okay, so just by way of introduction so that you guys understand where Geisinger Health System is, we're based in Danville, PA, and we serve a rural Pennsylvania community. So the areas that have kind of outlined on the map are where we have the bulk of our services. We really are in the rural environment. Pittsburgh and Philadelphia are outside of our traditional care area. We do have 5 hospitals that are basically take care of patients in the central area by the circles. There we go. We have about 70 or so clinics, 40 or so of those are primary care clinics. I don't know why that keeps doing that. Am I hitting the wrong button? Okay, we'll just go on to the next slide. Really what I wanted to communicate to you is what we are... I didn't touch it! Just go to the next slide, if you will. I only have 3 slides, so this will not be a significant problem. What we are really trying to do is expand the contact we have with the patient, because in the clinic, for most visits, you've got, 15 minutes? So if you can only interact with the patient during that office time, you're pretty limited in what you can get across. And for those of you that are in the clinical setting, you understand that there's so many things that you're expected to do around education and diagnosis, et cetera. It's really a small amount of time. So through technology, we can help expand that interaction you get with the patient. We can also focus it. So one of the things that you're required to ask is, does the patient smoke? All right? So I don't really have to waste a clinician's time with asking the patient whether they smoke or not. I mean, I can just do that as a question to the patient on check-in or over the portal. It's a simple yes-no question, right? Where you want the clinician's time is if the patient smokes, talking about the smoking behavior and the impact to their health. So what is it that I, from an eHealth perspective, can do to really take those data gathering types of questions and ask them to the patient and take the results and funnel that into the medical record so it's available for provider support. So the provider's 15 minutes with the patient can be focused. It can be not on all of the administrative stuff they need to do, but it can be very much on why the patient's here or what else you might want to tell the patient about their care to help them improve themselves and have a better condition. So we are doing a lot with patient-reported data. We do as much as we can through the patient portal, and I envision in the next 6 to 12 months, I'll basically have a culture where you're going to have a pre-visit before your visit, approximately 2 weeks before you come in. I'm going to ask you to do some things online. I'm going to ask you to fill out a few questionnaires. Ultimately, my revenue cycle department is asking about, can we get them to fill out forms too? And anything to make the time in the office more productive. So what can I give the patient prior to that? Then have all of that data available for the visit and have the visit very focused. Likewise, you have the visit. The provider makes a certain treatment plan with the patient. How can I check in with that patient before the 6 months goes by? I mean, some of us are not very good patients, and we stop taking our meds because of side effects. We don't ever bother to call the doctor's office. So you come in 6 months later to find out that you stopped taking your meds 6 weeks after they were prescribed. And so the provider has now missed an opportunity of 4.5 months to get you on the right treatment plan. But I can do a questionnaire over the portal, and some of us are more comfortable with that. I'm not face-to-face with you telling you I didn't take my meds. I'm on a portal just answering some questions, and for some patients, that's more comfortable. We also do a follow-up, for example, to bariatric surgery. Some patients do really well with it. They travel an hour and a half to come in and see the doctor and say, yeah, I'm fine. And he says, you're fine? Great. Okay. End of conversation. That's a problem for them, for the patients that really need to be there. And it's a problem for the patient who just wasted a bunch of time for a 5-minute visit that they didn't need to. So we have a process where 2 months after the surgery, we deliver a questionnaire through the portal. And if the patient answers the questions in a certain way that show that they're not vomiting, they're losing weight, all the things that are important for that particular surgery, we don't have them come in. We say, great, we'll check in with you again in 2 months. So how can we integrate these devices to take better care of the patient? A couple more thoughts. I am dabbling in text messages and mobile apps, and I say dabbling because I haven't figured it out yet. Just started a weight loss program. I want to see, does that somehow help the patient? Do they like it better? If it helps them lose weight, great. But even if they just prefer that as a communication vehicle, that would still be a success. All right, how do I deliver information to them in a way that they respond to? So the patients are being signed up in the clinic, and then they get rolled on to the program, and then they get followed up in the clinic. Same from a mobile app perspective. What can I do with a mobile app where I might be able to essentially prescribe it to you? We're looking at, I mentioned earlier this morning, cardiac rehab. We're also looking at something for COPD exacerbations. Maybe I can get some data from the patient during the process and have that fed back into the medical record. So those are the types of things that we're trying to do. They all have, for the most part, some kind of clinical purpose or patient preference purpose. So I'm not trying anything just to try cool technology, all right? I am trying cool technology when I feel that it has the potential to impact something that the organization feels is important in terms of patient satisfaction or quality or safety or those types of things. Okay, thanks.
Thank you, Shannon. Next up, we have Han Pak, who is the CEO and Director of Diversinet. Han is responsible for the operation of the company with a focus on providing healthcare organizations with an agile, secure mobile application platform for secure messaging. Dr. Pak is a recently retired Chief Information Officer of the U.S. Army Medical Department, an $11 billion healthcare system with more than 60,000 employees. He was the Army's first CMIO prior to his promotion to CIO. He also previously served as president of the American Telemedicine Association, leading the effort on global health and standards development for telehealth. Han?
So does this work, or sort of? Okay. So it's a pleasure to be here. Given my background, being a clinician and also having been in telemedicine, this whole definition around point of care is very interesting because it is shifting in a very significant way, in my opinion. And it's shifting on the mobile device in ways that I think is pretty interesting. So from our perspective, here are the things that I'm seeing. One, we, the healthcare community, understand very little about how to engage patients in a customized, personal way. And I believe we're in a journey, in a very early journey, to figure out who and why we make the decisions we do as individuals, and what we can then learn to then customize and personalize care. The reason you go to the local Starbucks versus McDonald's sometimes is because they know your preference of your coffee. In healthcare, we don't do that. In education, we go into a classroom of 1,000 and a teacher delivers a content, and the hope is that most of you will get it. Healthcare is similar to that. And I believe that what is happening is this advancing with that? Yeah. Anyway, it's throwing me off a little bit. I'm not doing anything, so if you could go back to the, yeah. Now I have a couple more than that. So can you go back to the second slide, please? And I believe the challenges that exist today are in a couple different areas. Can you go back to the second? Can you go down one then? What happened to the slide that the challenges? 2 slides back. There we go. Thank you. Sorry. Hey. So a couple different areas that we see as challenges. One is our understanding and the need to experiment and innovate around how we engage patients. That's not a mobile problem. That's a healthcare problem. But we need to understand what it means from a mobile device perspective, number one. Number two, I'll share a very quick story about my daughter who came home the other day, very excited. She knows that I'm running this mobile app company. And essentially she says, "Dad, I just had my vaccine and I got an app with it." I said, "Oh, that's so cool." And then I realized, oh my God, that's a problem. One doctor, one vaccine, one app. You multiply that by how many and what that means from consumer's perspective. How many apps do I need to really have to manage my health? So interoperability of these mobile apps and a set of standard terminology and a framework is absolutely needed. And then from an integration perspective, I think particularly as it relates to the point of care, we are talking too much about patient engagement, but rather I think we should change the language around provider-patient engagement. The reason being that these things don't happen in the silos. If you look at the PHR as an experience of how Google and Microsoft HealthVault and others have succeeded or not, depending on how you define it, most people would say the Kaiser's experience and the Geisinger's experience success is because it was tethered and it enhanced engagement between the provider and the patient. It wasn't a tool for consumers to do whatever they wanted to access the data. And so to that extent, I think we should think about this prescribing an app, but not prescribing an app for every condition, but prescribing an app within the workflow so that when you get discharged, something gets triggered, and on the mobile device, a set of instructions that typically is on a piece of paper would start tracking of whether you're adhering to those instructions or not. I believe that that's what's impacting and where things are headed. So very quickly, I hope if I can control this. Next slide, please. So our technology is trying to address 3 different areas: the security and the privacy, bring the platform to integrate with our workflow and bring agility, and then bring interoperability. Next slide. This is just the way our model, our technology platform addresses both the authentication and the encryption. We're the only mHealth platform that addresses or that has the FIPS 140-2 certification by NIST, which essentially puts it at a much higher level for your lowers the liability and the risk. Next slide. If you could build that one more time, please. Can you down arrow? So this is, I don't know how many of you have been following National Library of Medicine's work on the Paul Esterbrook's effort on the harmonized patient data elements. So it's a little similar to the previous speaker mentioning about patient-reported outcomes. And essentially, they have determined that these determinants of health exist, that these domains around how you sleep, and various other factors weigh into the variables in which how we make decisions. We now have the ability to store that on top of the PHR securely on a mobile device and then create a set of interoperable applets on top. That's our platform. Next slide. Why is the interoperable apps important? If you have a patient with asthma app, if you have a patient with a number of different conditions, there's really no way to bring together those set of data from those elements in a meaningful way for me to make a difference. So this is an example where having applets that are interoperable that says this is a patient with clinical depression, the mood seems to be going down along with the adherence of the medication. That's very meaningful to me as a provider if I see someone versus if it was trending in a different way. Next slide. So again, I believe that the point of care is shifting to the mobile device, and we believe this concept, what we call the mHealth wallet, brings a new model for engagement, allowing patients to store, manage, and share their data securely, and then creating this new set of profiles in a standardized way based on the NLM work, I think will really help propagate this. Next slide. And then here's just some of the components of the National Library of Medicine work that we are incorporating into the Health Wallet. So you can see, sleeping quality, physical activity, eating patterns, all those really do make a difference in terms of how we manage individuals and patients. Next slide. And then I just wanted to let you know that the Army mCare program essentially is warriors that have come back from the war, Afghanistan and Iraq, that have PTSD, depression, stress, and so forth. And case managers are the ones using this on the consumer's mobile devices to engage in their care and track what they're doing. Next slide. So that's all I have. Thank you.
Our next presenter is Michael Yuan, who's the CEO of Ringful Health. So Dr. Michael Yuan is a recognized expert in mobile health and patient engagement technologies. He is the principal investigator of an NIH-funded research project, as well as co-investigator in multiple federally funded projects. He is winner of multiple developer challenges from Health 2.0 and Robert Wood Johnson Foundation. Dr. Yuan has also published 5 books on software engineering and mobile application development. Some of those books are multi-year bestsellers in their categories. As the CEO of Ringful Health, he has led the company through early stages of growth with diverse customers ranging from major hospital systems, national patient and consumer advocacy groups, to publicly traded technology companies. Michael?
Okay, I'll do a demo from my iPad. Thank you, Brian. So, Ringful Health has been engaged in mobile health since 2008. During this time, we've seen a lot of companies come and go, and a lot of fad about technology, about different ways to engage people. And I come to realize that mobile health really is about stakeholder engagement. It's about delivering the right information at the right time, at the right place. So, instead of talking about patient engagement, the particular demo I want to show you today is really to demonstrate engagement of another kind of stakeholder, which are nurses in the hospital settings. And you'll see in a minute after the demo why it's easy to convert this type of application to patient and family engagement while they are staying in the hospital. So the background of this is, there's many major in-hospital adverse events, such as cardiac arrest, stroke, and sepsis. They kill and harm thousands of people every day in the U.S. And those events are huge financial burdens, and as health reform progresses, many of them are not going to be reimbursed in the future, which creates a huge financial problem for hospitals. However, studies have found that 80% of in-hospital cardiac arrest show symptoms that can be detected by nurses 4 to 8 hours before such events. Similarly, sepsis and the stroke have similar patterns. But it's just the nurse, this is what they often call the golden hours. But the problem is that the nurse often is too afraid to speak up or doesn't have the decision support at the time when such symptom changes happens. So this is the problem that has plagued the healthcare system for a very long time. So since 2005, almost all U.S. hospitals have invested a tremendous amount of resources to come up with something called a rapid response team. Many of you probably have familiar with that. Those are standby clinicians that does nothing but to respond to those emergencies, and they get called like several times a month, which is, in a lot of people's opinion, it's it's vastly underutilized. They should be utilized a lot more often to do those things. So the mobile health solution I'm going to present next is a clinical decision support tool on the iPad. It's designed to help nurses recognize dangerous conditions and communicate with rapid response. So the device will be deployed in 17 acute and long-term care facilities. It's in part funded by a $1.6 million grant from the Medicare and Medicaid Innovation Grant. And the application is designed to fit into the nurse daily workflow, so let's start the demo. In the demo scenario, we'll show a nurse using the application during a hypothetical hourly rounding. So the nurse goes to the patient's bed every hour to check upon the patient. And the nurse first scans her badge because I have this extension port connect to there, so I don't have an optical scanner with me, so I just type in the nurse badge. And then for each patient she encounters, and they would scan the patient wristband to identify this patient, right? And then the next thing that comes up is what they call a rounding form. And this is an interesting EHR concept. In the hospital that we deploy, they all have this thing called rounding form that's in the EHR. But when we do a study, how many nurses actually use those EHRs? Those forms, none, because it's a very long form, and they have to do it on the paper and then go back to the computer to transcribe it. Virtually no one does it. So this type of information currently is completely undocumented. But by connecting this to the EHR, so right here we have a tablet device that can connect to the EHR that provide value of something that nurse doesn't use today. So let's say what's the nurse find about the patient. And the nurse finds about the patient is there's some mental status change, and the patient is breathing very hard. And and in this case, the nurse saying next, because those two right there are what we call warning signs, because those two indicate there may be something wrong with the patient. So instead of move on to the next patient, the device asks the nurse to do more investigation. And what happens here is you can see the two-panel wheel here, and it's a simple user interface, but underneath it we utilized Bayesian neural network and machine learning techniques to map those symptoms into possible outcomes that this patient might have. So the numbers associated with each of our outcome is the probability of this thing happening. And on the right-hand side are the things that the nurse needs to check. As you can see, those at the bottom of the page, those two already checked, shownness progress and mental status change. So let's say the nurse finds the patient's nurse took a pulse of the patient and find the pulse rate is very high. And while the nurse is taking the pulse, she also noticed that the patient has a fever. So the body temperature is high. And right here, you can see that at least the computer thinks that there's a very high chance the patient is having sepsis. And as I just said, sepsis is one of the most difficult things for the nurse to notice. There's enormous training programs that help nurses recognize sepsis because all the signs of sepsis is subtle until it's too late. So, and the sepsis case easily costs the hospital $250,000 per case or something like that. And so, in this case, the nurse, the computer tells the nurse that there's a high chance of sepsis, and at the same time, through the internal paging system, this tablet device has already notified rapid response and asked them to come. And while the nurse is waiting for the rapid response to come, she can hit on the sepsis, outcome, and then see the immediate actions she needs to take. And there are things that she needs to anticipate. Although the nurse is not authorized to provide treatment, but she can prepare for the likely orders the doctor or the rapid response team can give. And when the rapid response team comes, the nurse hands over this tablet to the RT nurse, and the RT nurse would say, would be able to immediately see what has been checked and what remains to be checked, and will be able to make a more informed decision and also talk to the physician about it. And now, that's a fairly easy user interface that I have demonstrated, and we have tested it, in a fairly large pilot in a hospital to see if it fits into the nurse workflow and how much cognitive load it's produced for the nurse. And as you can see, this can be easily converted for the patient side as well, because a lot of hospital has since has the concept of patient-activated rapid response, and in some of the hospitals we're working with, we hear anecdotal evidence that people call 911 from inside the patient room, right, because they cannot get the nurse to respond. So they have this concept of patient-activated rapid response, and the patient would be able to activate the rapid response and come to them and see what's wrong with their loved ones in the bed, and this tool would help them to provide meaningful communication between the rapid response. And now the most important aspect of this application is, I can get into the buzzword, is that it collects the diagnosis. Every time the nurse uses it, it collects the outcome, it collects the findings the nurse find and the outcome that it's you think is the physician or the RT determine the patient have. So so the system is designed so that it learns from its own data, right? So it's because it's being used on every patient every couple hours. So enormous amount of data can be collected through a system like this, and by analyzing, using machine learning algorithms to find out which the probability of each findings associated with each outcomes, the system could learn from its own from its own use, and then find out which are the important findings in a particular clinical setting. So, for instance, in a pediatric, in an oncology ward, it's probably the things you're going to check for sepsis is different from, say, some other surgery unit. So so that's it for my presentation. And so we are I'm demonstrating this, and we are looking for additional acute care locations, and to participate in our trials and see how well it works in other settings, in other care settings. Thank you.
Great, thank you, Michael. Our fourth and final presenter is Pierce Grant-Jones. Pierce is the West Wireless Institute Innovator in Residence Fellow at the U.S. Department of Health and Human Services. His current work is focused on developing new tools to demonstrate the power of open data and expanding the Health Data Initiative through public-private partnerships. Pierce was a management consultant for 4 years at Monitor Group before joining the government. He has spent the last 3 years writing strategy for the Office of the National Coordinator for Health IT, ONC, serving as David Blumenthal's special assistant, helping manage the $250 million Beacon Community Program, and co-authoring the healthcare chapter of the FCC's National Broadband Plan. He holds a Bachelor of Arts in English from Middlebury College. Is that right, FCC's? Or a different one? Same one, right? Okay. Please welcome Pierce to the podium.
All right, thanks, Brian. At the Office of the National Coordinator for Health IT and at the CTO's office at HHS, we work on opening up data, promoting standards, and encouraging better process and payment so that mHealth technology can flourish. As the technology advances, we work to encourage its adoption at every point in the delivery of healthcare. So a little disclaimer, I'm a little out of place because the initiative I submitted for this conference is explicitly not a point of care initiative, but but I've been working on 3 different mHealth related initiatives over the past year, so I thought I'd just give a little status update on each of them, and hopefully they'll be good fodder for the discussion today. So first is, could we go to the first slide? Great. The Text for Health campaign. It's a public health campaign using text messages to help individuals better understand and act on their risk for type 2 diabetes. It was designed and implemented by 3 Beacon communities, which are among the most advanced regions in the country in using health IT to improve health outcomes, and Geisinger is one of them also. They recognized that care in the delivery system was not enough, as Shannon was saying. They wanted to increase their touch points and ability to improve health outside of the care setting. And they decided to use texting technology to improve upon the traditional public health campaign model. Working with a vendor, Voxiva in this case, they custom built a new texting product that led individuals through a multi-step risk assessment process, and then connects them with resources in their cities that could help them act on that risk. Promotion of this intervention got a lot of support. This was one of the coolest parts of the whole intervention. Is it got a ton of support from Blue Cross Blue Shield, Walmart, Kroger, a lot of private entities in each of these 3 communities, Cincinnati, Detroit, and New Orleans. And they work together with these partners in designing and implementing the public health campaigns. But I think one of the other innovative parts of these campaigns was that they each had a very narrow goal. It was just one thing: text health to 300, 400, and then that initiated this texting process to better understand your risk and act on it. The campaigns began last February, and they've so far enrolled 3,400 participants across the 3 cities. It's too early yet to see the program's success in moving patient activation measures. We don't have the evaluation results in yet. But we do know that engagement has been pretty decent. 60% of the participants set a weight goal at some point during the program. 73% reported at least once on their weekly exercise levels. 72% reported at least once on their current weight. And about 33% dropped out each month. Can we go to the next slide? The second initiative I've been working on is called the Million Hearts Risk Check Challenge. And this was actually modeled off of the Text for Health campaigns. This time as a joint effort between ONC and the Million Hearts Initiative, as well as SureScripts Corporation, Archimedes, and a number of pharmacy partners. Like Text for Health, we're designing a new product and a public health campaign promoting that product that will help, in this case, understanding their cardiovascular risk and acting upon it. We did things a little differently with this intervention. First, Archimedes took their state-of-the-art risk analytic engine and algorithms, and for the first time, custom built so it could be done just off of consumer entered data. So usually that's an algorithm they use in the care setting, but they designed it so that it could be a public health intervention. Second, we worked with SureScripts and their pharmacy partners to, for the first time, create a centralized directory of locations where you can go for lipid and blood pressure screenings, and they made that available through an API. And so we took those two APIs, and we used our app challenge mechanism. We put out a challenge for $100,000 and said, take these two APIs, mash them up, and create a really, really cool user interface and design that's going to engage a broad number of individuals in America. And then we, so Farzad Nassashari and Harry Tatonis, the SureScript CEO, and Jana Wright announced the finalists for that challenge this morning here. And we are working on campaigns right now in 5 cities, and also as part of the National Million Hearts Initiative that's going to take the winning app from that challenge and promote it around the country. And can we go to the next slide, please? All right, and third, I'm the initiative coordinator for the what's called the Automate Blue Button Initiative. One of the biggest challenges that I hear all the time from mHealth developers is access to personal clinical health data and personal financial claims data. If we had this data, we could give a much more powerful tool, give a much better insights to our consumers. And there's a ton of reasons why it's hard to have access to that data. But the blue button has actually done a minimal viable product incremental step towards that. VA created the blue button 2 years ago with a very simple mechanism. They just put a button on their portal that gave an ASCII text dump of all the personal health information available to a consumer already on there. And they said, okay, well, now we're giving electronic access to personal health data. Just having that simple mechanism has been somewhat powerful because you've seen a lot of adoption across the industry. Now Medicare offers it to all their Part A, B, and D beneficiaries. Aetna, United, Blue Cross Blue Shield Association have all started implementing the blue button on their portals. What we're trying to do now through the Automate Blue Button Initiative is, can we go to the next slide, is advance the standards associated with the blue button. So right now it's an ASCII text dump. But what we're hoping to do is is move away from that text blob and say, let's associate standards with the blue button so that now all these hundreds of millions of consumers that have access to data, they'll get it in a common structure. So for clinical data, we're following meaningful use stage 2 and using the continuity of care document in the consolidated CDA standard. They also want to include transport with those standards so that it's not just a one-time download, but that an individual could actually set up the functionality that data is sent once and then sent every time it's updated to the app and service of their choice. So this is a standards and interoperability initiative at ONC. We've been working with a really great group of data holders, so most of the major HR vendors, most of the major payers, standards geeks and techies and all sorts of a big crew on what these standards could actually look like, how hard they'd be to implement. And we're hoping to sort of start iterating on the Blue Button standards by HIMSS this year. All right, so those are three. Thanks very much.
Great, so that takes us to the Q&A discussion portion of today's session. We do have about a half hour left in the session, so we'd love to get some interaction with the audience in just a few minutes. But I thought to lead off, I think more than any other, been looking at this space for the last 4 or 5 years, it seems like 2012, the role of the physician has really become a much more prominent one, I think, in mobile health. For years, it was sort of, this is going to be very consumer-directed, it's going to be more of a consumer health-driven movement, and it's going to take a long time for these physicians to get on board. So for now, use them as advisors, but kind of ignore them as a channel. But it seems like this year, in 2012 especially, there's a lot of talk of, it usually takes the form of prescription of apps, prescription of these devices. But in general, the idea of point of care, that office visit as being a time when a clinician could maybe help drive adoption of some of these technologies, seems to have become a very big trend in 2012 as a likely thing that's going to happen now and in the future. I was curious if the panel could weigh in on that, the role of the physician in general, how has it changed? Do you see them or other clinicians as being the primary driver of adoption in this space? Doesn't have to specifically be prescriptions, but something along those lines, and I thought it'd be appropriate to start with Shannon.
Yeah, I don't do any projects without a physician sponsor. As I said, we're trying to impact the way we do patient care. So it's really critical to work with providers who are willing to try new things. From an administrative side, I'm not going to get very far. So to the extent that providers are now willing to try these experiments, I think that they are getting more involved in non-traditional ways of performing care. I would also say that from a patient perspective, we do get more compliance with when you're sitting next to your doctor and the doctor says, I want you to do this, versus trying to enroll them using a letter or an email broadcast or those types of things. So that's certainly a role that the patient has decided is important for them, and patients seem to be more willing to do things that their doctor asks them to in a face-to-face setting than if they just do it, form letter or an email broadcast type of thing.
Pierre, I noticed in your presentation that for the Text for Health initiative especially, used a lot of different methods to get the word out. Did you use physicians as well? Was that part of the...
Yeah, they did flyers in the physician's office, but we tried to not meddle with any physician processes for that intervention because it's supposed to be a public health intervention, so it's really not something. It's actually supposed to precede the physician visit, and that outreach to the patient.
At the recent ATA, there was a speaker from Toronto that talked about a case study. I think it was actually a clinical trial. They actually looked at patients with hypertension, and they separated them into 2 groups. And in one group, they actually tried to create a intervention around engagement to try to reduce cardiovascular risk and hopefully, therefore, the outcomes. So they did it with mobile apps, but they also did it as a comprehensive program around around their cardiac care and high blood pressure specifically. And over time, they actually showed that this intervention group actually lowered their cardiovascular risk by whatever the formulas they were using by 20%. And so these were valid instruments that they used to actually show the decrease in reduction or engagement, as you said. But then they actually said, okay, what's the outcome difference? So we got them engaged. Their blood pressure's down by 20% along with their cardiovascular risk. So what? And it turned out that the outcomes were no different. And the reason between the two groups, the one was engaged and not, and this really gets to the patient, the point of the provider engagement, and that is, in the case around provider engagement, the providers were never engaged. They were getting data fed daily on blood pressures and all the data that they did not know what to do with. And so I think it's really critical that whatever we said, we need to understand that point of care is shifting. There are massive amounts of data now that can be produced. That doesn't mean that's a good thing. And so I think you're right. We have to begin to look at the workflow of the providers and begin to understand what are the impact of these applications and how do we ensure they not only activate or start the process of engagement, but then manage all the data associated with it.
Well, I can share something from early days of Rainfall. So we started in 2008. We had a bunch of consumer applications. We have one of the first allergy and asthma applications. We have award-winning pain applications. And all those, we thought, those are slickly designed applications, at least at the time. It may not look so fancy now, but, I thought they are sure to engage patients and have them do things so that to better manage their disease condition. Truth to be told, yes, a lot of people download those applications. They use those applications as a novelty, like they use a game, right? They use it for a couple of times. And the dropout rate is astonishing. It's very high. That's people tried it for a couple weeks. I would say a couple of weeks would be, a pretty typical, length of time. That's people would delete those applications from their phone, and we talked to a few patients, because some of the app were featured nationally on on things like Wall Street Journal. So we talked about with some patients about what's the barriers, and it was invariably that's when I go to the physician's office and I show this app to the physician say, what is this? Then they just lose all the incentive to continue to use that because there's no point putting all those efforts just to be dismissed by the care provider. So so that's also one of the primary reasons as a business we get out of the consumer-driven application space is that we don't see the way to change this. It's a too big a problem for a small company to tackle.
Yeah, I think, we talked about, I think during Shannon's presentation, this idea that most of us are used to going to the doctor maybe every 6 months, every couple months, or every year or two. And so this idea now that there's the opportunity to have many more touch points, I'm curious, what's the strategy there? I mean, you'd mentioned a couple of different ones. How do you get that number right? How often is too often? How do you kind of triage and make sure you're not, bombarding the patient as well as the doctor? Any best practice there you can share in terms of determining the right amount of these kind of remote visits or remote check-ins?
Well, let me just say we have not figured it out yet, but it is something that we're looking at, and we've dubbed it as we need what we've called an air traffic control system, because it's now that we're pushing more out to the patient through questionnaires. We have standard revenue cycle sending appointment reminders, text messages. We have something called a happy birthday letter. Once a year, you get a reminder of all the things you're supposed to do based on your gender and your age. And you do get to the point where you can be spamming the patient. And right now, we do operate more in a silo-based approach. And what we're trying to do is find a way that we could get a technology solution in place that could help us monitor all of those different contacts so that we could put some business rules. I don't know what the right communication model is, and I think the way we're going to get there is we're just going to keep asking the patient. So one of the things I can do, because I have the patient portal, is I can put up surveys, and I can do that relatively easily. And anybody who goes to the patient portal can take it, and so I often get 500-600 responses in a week or so. And I'll just keep asking them questions like, are you interested in text messaging, and what kind of text messages would you receive? And that helps me figure out what the patient is actually looking for. So we've asked a number of questions on communication preferences, and we'll continue to do that. But I certainly haven't solved that problem yet.
I know with Text for Baby, I actually, as every good mobile health journalist should, I signed up for Text for Baby, so I had a fake pregnancy for about 10 months. And I was getting tips about it, I believe about three times a week. And I didn't, I don't sign up for a lot of different text services, so it was very much, on my screen, and definitely started a lot of interesting conversations with my wife and other people. I'm just curious, if you were part of that decision making, I know Text for Health is taking a lot of lessons from that initiative. How did you come up with that number? Did that work? Does that bring about the right level of engagement that you were looking for, and any feedback that you've gotten in terms of quantity of messages from?
That's something Bugsy has been really sort of driving, I think, on sort of understanding the number of text messages people like to get, and at least for their products, and then tweaking it. And I think it's just been a pretty much learn as we go process. I don't know if there's any sort of research or anything to base it off of. So started getting a feel through the initiative, and then modifying as we go on.
Great. So, we talked about point of care as a place, as a channel to drive some uptake. We've talked about some of that frequency of between visits. How often should you really be reaching out to the patient? I'm curious then, when there's that follow-up visit, the next visit, after some of these solutions have been out there, are we starting to see already from some of these initiatives a change in that visit? Has that point of care visit transformed at all yet? And if not now, how do you expect it to change in the near future? Han, is that one you can hand first?
So right now, I think using the two other clients that are using our platform at the point of care, particularly for case managers, I think in that situation specifically, the soldiers that have come back from the war with various different medical conditions are not getting their best of care or forgetting because they have traumatic brain injuries. And so I think it has fundamentally allowed them to engage and get reminded, and so the results will be published for the phase 2. But the phase 1 data was clear in terms of we learned a lot about when do they engage, when do they seem to respond to the text versus other times that they don't. So it is interesting that we're beginning to get some data, but I agree with the speakers that I think we're in the early days. We have no idea. We're just beginning to understand how. But I think part of the important thing that I've learned for the Army's program is that I think if we try to study this at the gross level, meaning if we say, well, do the patients best respond to their text at 10 o'clock in the morning versus whatever, I think we get an average answer that doesn't tell us much. I think it's rather if we all came up with a set of terminologies that said, okay, let's measure it this way. It may not be perfect, but if we said, here are the ways we're going to ask these questions, here's the way we're going to do it, if we did it in a constructive way and all of us use that model, and then use that as a preference for individuals, I think we'll get much better information and fidelity around individual preferences, even in communication. So it turns out that individuals prefer different communication styles. Some people still prefer emails. Some people, younger ones, particularly text messages. So if you can begin to set a profile around individuals, then I think that has a further advance in terms of how we understand who does what and why, because it is clear that if we take an average approach, we're just not going to get that change.
Great. Well, I want to make sure there's plenty of time for questions from the audience. If there are any, please feel free to step up to the mics, and we'll take them as they come.
Hi, I'm David Dubbs. I'm previously the head of innovation at Medco before we got gobbled up by Express Scripts. So on the provider side, there's no question that healthcare is big data, and a lot of that information is being stored in these EMR systems. And as you look at, for example, Kaiser, which is a great example in that the workflow in Northern California is different than the workflow in Southern California. So after a $5 billion implementation, they have a system that Northern California doesn't talk to Southern California. And so if it doesn't happen at that level, what is the expectation that we could possibly get interoperability across all of this big data? And as you, Dr. Pack, were talking about interoperable applications on the consumer side, there's just, and Shannon, you're looking at dabbling in mobile applications, you say. There's just this explosion of applications. And so you've got all this information, you've got all these applications, and how does a consumer sort of make sense of all of this stuff?
I would say from a patient perspective, the way we try and focus the patient information is by having a very robust patient portal, and that the clinical information, the interaction with your provider through messaging, the scheduling of your appointments, the taking of questionnaires, the putting in your blood pressure or glucose, those all happen within the patient portal. So we do try and keep the patient communication back and forth with the system in a focused area. I don't have text message integrated with the patient portal yet, so we'll see exactly how that works out. From a provider perspective, for us at Geisinger, it's the medical record. So all of these mobile apps and anything I do, I will likely be trying to figure out what kind of integration level can I put between the medical record and all of that other stuff. Because it's been in place since '96. It's very much part of the culture. That's where providers want to see it. In addition, that's where we do our medical decision support. So if we're trying to alert the provider of a certain situation with the patient, it all happens in the medical record. So I think, in some sense, we have to have some focal points. And so we've got to figure out how do we leverage those focal points and take the data from the disparate systems and funnel those in.
The one comment I have in terms of big data, I think most people think about genomics and that type of data, but I think this particular community, the mHealth community, really need to think about social data. If you really look at the NQF reports and others, it's clear what they said. They said now that we're getting adoption on the EHRs and beginning to amass these data in these integrated delivery systems or hospitals, the problem is there's an absence of a set of data that tells us who the patients are. Most of that data is on the social side. So I think whoever can figure out the merging of the social side, what's happening when you shop and do daily living, to what's happening in the space, I think is really the answer. But to really answer your question, I think the data interoperability, in my opinion, could be flipped on its head if we give patients the data. So if we take Dacia as example and create the HIEs and then flip them into a kind of a nonprofit data bank, create or say, in order for you to get paid as a hospital, you have to send the data, a copy of the data, to that bank, and then the patient then is able to then take that data and have an app or have a set of interactions associated with that. And I think that's how we're going to achieve it, in my opinion. I think right now the current paradigm is very difficult to get to where we need to go, and the direct, obviously, there are a lot of standards and all kinds of challenges. So I think I'm talking with a couple of folks in ONC and others about taking the blue button. How many blue buttons do you need? Should we not have one? But in order to do that, that means you've got to have a central store. And I think it's unreasonable to bring all the hospital data into one. You could federate it, you could do other things, but I think we should do a patient data bank.
So I'll build on that one. I was going to make, is this microphone working? Yeah, okay, sorry. So I was going to respond also by saying, for a lot of mHealth applications and consumer and apps that are designed for consumers, it's more about consumer-mediated exchange and the consumer getting access to their data than I think the big data. Big data is more of a challenge for analytics companies and others that are trying to do population-level analysis. And on the personal level, I think I don't know if any of us need to manage a central store, but if we could get if we can give a consumer standardized, consistent, machine-readable access to their data, then they can power apps and many different types of apps and services that would be able to synthesize that data across systems, across the country, and build analytics and other sort of decision support tools for those consumers off of that synthesized data. That is exactly what we're trying to do on the Automate Blue Button initiative. It builds off of Meaningful Use Stage 2 is going to be a huge contribution, I think, to this challenge. I don't know if it's enough, but it's a big contribution because every EHR system is going to have sort of tunnel into it because they got to be able to send a direct message, and they got to be able to generate a continuity of care document in the consolidated CDA standard. So, that's transport, that's machine readable, consistent structure. And so I think what we're trying to do on Automate Blue Button is kind of do the last mile for the consumer, so that an app could actually be able to receive that direct message, receive the consolidated CDA.
Could I be a little controversial on this? So I think that is great. I think we're heading in the right direction. But the problem is, what if you have 3 CCDs? Who's going to reconcile the medication? Who's going to be the truth? I think we have a big issue right now. I absolutely believe this is the right path forward, absolutely. But I think we have to begin to think about, do we need a patient data bank concept for this consumer data approach? My belief is we need something like that. And if you put it as part of the HIE, in my opinion, then you have the convergence of hospital data, consumer data. And I believe in that focus, I think the analytics will learn a lot about things that we have no idea why consumers do what they do.
Another question in the back?
I'm Madhu Ramaswamy. I work at Innova Health System, a local Washington, D.C. Hospital provider chain. I'm a critical care physician, and I have obviously great interest in Michael's application. As a specialty, we take care of patients with sepsis, progressing on to severe sepsis and septic shock. It's a diagnosis we own and treat. Our analytics division worked with us and created a sepsis alert system. Unfortunately, it seems like our EMR data would sort of go into it. They would use an algorithm, generate something, send out an email every morning. The general perception is it's too sensitive, so everyone's learned to ignore it. Alarm fatigue. So every morning, 15 people get the email. Everyone hits the delete button and moves on. Question is, I see that in your application, unless I have this wrong, you're relying solely on the bedside provider, which is a nurse sort of keying in variables. You're choosing sort of not to link in lab data from the EMR. That's my first question. The second one was, how long is each encounter taking the bedside nurse to complete?
Right. So yeah, we definitely do link to the EMR. Whether to link to EMR is a practical matter. That's because a lot of the stuff we do on our checklist are vital signs. So yeah, they are readily available from the EHR. So and also the medication history. So the patient displays certain things that may be consistent with the narcotic drug he's taking. So that's so those all goes into the decision mix. So definitely when we do aggregate EMR, the only place that we require clinicians to do all manual input is the place where there's no EMR, like a nursing home. So they have done everything on a piece of paper so far, and so it's very interesting that a lot of those scores are sensitive. That's also precisely the reason why we don't use a fully automated approach, because there's a big cultural problems in the hospital. So one of the first things the nurse learns when she goes to the hospital is not to raise false alarms, because if she sees the patient that she thinks has a problem, and she calls the physician and interrupts his dinner or whatever, and the patient turns out not having a problem, she gets yelled at. And the next time she learns to wait until the last possible minute to call the physician, because that's until she's absolutely sure that the patient is dying. So that is a huge problem. That is why you got a 4 to 8 hours early warning sign window and nobody calls. It's not because nobody recognizes this. It's because people are too afraid to do anything. And so that's also a whole concept of rapid response, that you have a passive escalation that not goes directly to the physician, but goes to the senior nurse first, and then to the standby hospitalist or the or the senior people in the hospital first, and then and all the communication is being documented and then sent to the physician. And also, just to build on that data question, there are lots of things that EMR doesn't capture. So for instance, in our things, in our data metrics, we have things like whether the skin condition of the patient, whether it's warm and not dry, or cool and damp, things like that. This is not a part of vital signs, not captured in machines, not captured by EMR. And also, one of the very common things, like a pulse oximeter, it's a thing you wear on your finger point, and then it tells you the oxygen saturation level in your blood. And you can have patients whose pulse oximeter reading is fine, but the patient is breathing really hard, meaning that he's really putting an effort to keep up this blood oxygen level. And as soon as he becomes exhausted, it goes drop down really fast. And this is not reflected on the machine, and it's not reflected on the EMR. You have to have a human being that's in the bedside and see this patient is really breathing hard in order to keep the blood oxygen level at 92% or something like that. And you know he's going to crash as soon as he, run out of strength, right? So things like that, that's, to echo on the point that other panelists have made about patient-reported outcome, I think there's also, there's a lot of things that are just not being captured in the medical system today. That's critical relevance to improving the predictive value of those systems. That's how to predict sepsis. If you just based on vital signs, there's so much you can do. But if you putting other variables in there, the patient medical history and all that, then you can do a lot more. That's hopefully that's our research would validate this approach.
So we have just a few minutes left. Time for one more question, if there is one. Okay.
Hi, Camilla Chung from Hopkins Bloomberg, and was a design architect for EMRs for 7 years. I actually have questions for all of you, and I was really interested in the last 7 years seeing how ONC's work has really spearheaded and moved and changed the EHR world in a great way, actually. Actually, my question is for Shannon. My mother's actually in the Geisinger network, and she does perform follow-ups with her physician electronically, which is awesome. I really like where you guys are going with the continuum of care, staying in contact with your physician and not having to go on that long journey to see your physician again when you can easily just have a quick follow-up in using other methods, electronic methods preferably. So in your work with physician champions and they're spearheading these programs, initiatives at Geisinger, what have you done, how were you able, or do you have any tips and tricks in how you get physicians to get engaged with that follow-up process? I imagine now that their visits are more consolidated, these are truly people that need to see them, so those are time-consuming visits, and then time away from seeing their patients to catching up with their follow-ups in their email or however way you contact. So how is it that you're able to be successful there?
So I would say that what we use is very typical of any project work you would do, which is I find change agents. So we don't look for the physician that just comes in and wants to do their work. We are looking for people that are interested in the technology space, that find apps cool or text messaging cool, or are so incredibly passionate about depression screening that they'll do anything for you. And so, it's very similar to any other model you would have. If I can find somebody who's a leader who's passionate about it, then I don't really have to do a lot of work. They sell it for me. I do not attempt to sell the clinical value. I am not a clinician, and me trying to explain to somebody why depression screening or the asthma control test or medication reconciliation is important comes off, unless I'm just giving a high-level overview, it doesn't come off at the level it really needs to be sincere about patient care. I need to take somebody who's trained in the field, who deals with patients on a day-to-day basis, to really drive that point home. What I do is I have a good business ear, and I listen to what the department tells me about their frustrations. They have all of these patients that came in and they didn't get treated the right way, or they missed certain criteria. I listen to what they are struggling with from a clinical perspective, and then I think about what tools that I have and see if we have a match. And then if we do, then I pursue that. But I am not a hammer looking for a nail. All right? So, I was a consultant for a long time, and we use those skills to really understand what the clinical department is trying to do.
Unfortunately, we're out of time, but I think that's a really great place to end it. That was a good closing thought. So please join me in thanking our panelists here today.